Good evening. I'm Dr. Aaron Bates with Southeast Orthopedic Specialists. I am a sports medicine and arthroscopy orthopedic surgeon, which means that I typically operate on shoulders and knees. I do some elbow arthroscopy and some other injuries about the elbow, and also do some total shoulder replacements. Today, I'm here to discuss how to preserve the knee. You've probably heard a lot about total knee replacements or knee replacement surgery when your knee is very arthritic. Well, I'm here to kind of talk to you about how to increase the longevity of your native knee due to either meniscus or cartilage injuries. So to first kind of figure out how to do that, I think the best thing we need to do is to have you understand the anatomy of the knee, because that's very important in conceptualizing certain injuries about the knee and how we go about treating them. And so on this picture on the left here, you have the knee with facing us. You see the femur here, and at the end of the femur, this white shiny stuff here is called cartilage. And you have the same thing over here on the top of the tibia bone. This is the tibia bone here. And then you have the fibula bone out here to show that this is the lateral side of the knee, and this is, or the outside of the knee, and this is the medial side of the knee, or the inside part of the knee. And so this shiny whitish stuff here, called the cartilage, is what caps the end of the bone and protects the bone. And it's the substance that you articulate on with your knee when it goes through a range of motion. Any type of injury to this cartilage could eventually lead to arthritis, and initially may lead to just pain and difficulty with function. And so with arthritis, there's global loss of this articular cartilage, like I'll show you in another slide here. And that's what we're trying to prevent. The other thing is the menisci, or your lateral meniscus here, a C-shaped structure here, and your medial meniscus on the medial side, another C-shaped structure. And those structures are what cushion the knee joint and protect the cartilage. If you don't have these menisci, then there's something called edge loading or point loading on the cartilage, and it puts a lot more pressure or force on the cartilage, and the cartilage can wear away quicker and things like that and develop arthritis. I'm not really going to go into ligament injuries, but you kind of see the ligaments here. You have the two cruciate ligaments, cruciate meaning cross, and so they cross in the middle of the knee. You probably heard a lot about anterior cruciate ligaments, or anterior cruciate ligament injuries, or ACL tears, and then probably very little about posterior cruciate or PCL tears. And then here we have your collateral ligaments, your lateral collateral ligament and your medial collateral ligament. Those are important in also preserving the knee joint, but there are in a talk all by themselves. We can talk 2 to 4 hours about those types of injuries. The other thing that need to know is that there's also the patella or kneecap that glides in the groove here on this portion of the end of the femur bone. And so we call this compartment the patellofemoral compartment. So there's cartilage up underneath the kneecap, as well as in the groove that it glides in. And that's what you articulate on. Also very important for function and not having much pain. And so when we talk about the different compartments of the knee, the 3 main compartments of the knee are your lateral tibiofemoral compartment, or we call it lateral compartment. So tibiofemoral compartment, we call it lateral compartment, or medial tibiofemoral compartment, we call it medial compartment. And then the third is your patellofemoral compartment, the kneecap that it glides on the end of the groove on the femur. So patellofemoral compartment. So those are important to kind of know and conceptualize when we're talking about these injuries. And so what I'm going to discuss today, a little bit about cartilage defects. This is an arthroscopic picture of a cartilage defect. And this is where you have, it's almost like a pothole in the street, so to speak. And so the rest of the street or the rest of the cartilage is very healthy, but you have this area here that's devoid of any cartilage. And we call this a focal chondral defect. And so typically X-rays of a knee like this still looks pretty good. You have good joint spaces and well-maintained alignment. But if we don't address this type of injury can become this, which is arthritis. Now we call it more like post-traumatic arthritis, not really osteoarthritis, but it's all the same. It's arthritis. And what arthritis is loss of articular cartilage. And so we don't dissipate the force across a knee joint appropriately by sharing the load, then the rest of the good cartilage will start to wear away. And then you have cartilage that wears away on the other side of the knee joint, and then you'll eventually get down to bone on bone. And then you have an X-ray that looks like this, where you've lost the joint space. You have a severe joint space narrowing there. The bones have gotten closer together because the cartilage is worn away. So it's my duty to try to keep a knee like this from becoming a knee like this. And that's what we're going to talk about today. So we'll discuss a little bit about how you present when you have these injuries, what I see on exam, the specific imaging studies that we look at to help diagnose these injuries, as well as how we manage them. And so again, soft tissue injuries of the knee, they kind of make up with ligament injuries. There's also some others besides these three, but these are three main ones. There's ligament injuries, which again, we're not going to discuss today, hardly. I'll make some mention of them. There's meniscus tears, the cushioning of the knee helps protect the cartilage. And then there's focal cartilage defects, and they can be split up into focal cartilage defects of just cartilage only, or we call osteochondral defects, which is bone and cartilage. Osteo meaning bone, chondral meaning cartilage. When we talk about meniscus tears, again, I showed you that you have a medial meniscus and a lateral meniscus. So you can have isolated tears of either of those menisci, or you can have them in conjunction with other injuries like an ACL injury. A lot of times with chronic ACL injuries that are not treated, where your knee is not stabilized, you'll have a medial meniscus tears, or it's easier to get medial meniscus tears because the medial meniscus is the main secondary stabilizer to anterior translation of the tibia on the femur. And that's also what the ACL does. So if the ACL is not there, then the medial meniscus sees a lot more pressure. In acute ACL tears, just by the way you tear your meniscus, you put more pressure on the lateral meniscus. Excuse me, just by the way you tear your ACL, you put more pressure on your lateral meniscus. And so a lot of times we'll see lateral meniscus tears with acute ACLs. These can be interchangeable, however. This is just how we normally see it. And when we look at the meniscus, you see here we have zones, different zones of the meniscus and different tear patterns. And so some tear patterns are amenable to fixation, some are not. And it's a lot of it is based on the blood supply to the meniscus. So the blood supply comes from the periphery here. So you see there's the red zone, and then further centrally towards the middle portion of the knee joint, you have the white zone, what we call the white zone. And so that's has less blood supply. And when you have less blood supply, you have less nutrients to heal meniscus repair. And kind of in the middle there, and kind of the transition zone, we call it the red-white zone. So how you get meniscus tears, over time, you can just, with certain twisting activities, or if you have a deep squat, hyperflexion of the knee with force, and then possibly a twist, you can pinch the posterior aspect of the meniscus between the two articulating surfaces that can cause the tear. You can have swelling right then, or you may not have swelling till the next day. It's definitely, you have some difficulty putting weight on it, difficulty squatting and stooping, climbing stairs, things like that. We talk about mechanical symptoms. And when we talk about mechanical symptoms, we're always saying is you have some clicking, popping, painful catching and locking. On exam in the office, I may note that you have an effusion, which is water on the knee. You may know it as water on the knee. But to me, there's things that I do in the exam to be able to detect swelling inside the knee joint, which is water on the knee, or swelling outside the knee joint. And so typically with these types of injuries, this is an intra-articular injury, so it can cause swelling in the knee joint. So that's an effusion. You'll have pain. You might have pain with hyperflexion when I kind of bend your knee all the way back. You may have some joint line tenders, and then there's some specific exam or tests that we do to determine if we think you have a meniscus tear. One's called the McMurray test that this person is doing over here. Another's called the Apley's compression test, which is this one here. And then you'll have X-rays. You have a baseline X-ray when you come in the office, and folks may think that they don't need an X-ray because they come in with an MRI already, but in fact, we can tell a lot from X-rays or what we don't see in an X-ray. So just like we saw this in the beginning here, you have a baseline X-ray and it looks like this, fairly normal. So you could still have this issue, you could still have a meniscus issue, but a normal X-ray. But it's good that we know that you have an X-ray like this versus an X-ray like this, because if you have an X-ray here where you have a narrow joint space and you may think that you have a meniscus tear, well, you may have a meniscus tear, but the meniscus tear at this point doesn't even matter. Fixing meniscus, cleaning out the meniscus is not going to help a knee joint that looks like this. And so that's why we get baseline X-rays. But again, with meniscus tears, they're typically normal. So then if we feel like you have a meniscus tear, we'll get an MRI. That's kind of the gold standard to diagnose a meniscus tear. And you kind of see this as a sagittal or side view of the knee. And it's one image, one cut. As you can see the femur bone here, the end of the femur bone, and then the end of the tibia bone here. And you'll see that's the front part of the anterior horn of the meniscus. And this is the posterior horn of the meniscus. So you see this little white or light line that goes through here. This is a meniscus tear, and this we call this a horizontal oblique meniscus tear. And so when we talk about what do we do when you have a meniscus tear, well, not every meniscus tear requires surgery. Some can be treated non-operatively. You have to understand that most meniscus tears don't heal on their own, but sometimes the symptoms may resolve on their own with things like physical therapy, anti-inflammatories. That's what NSAIDs are, non-steroidal anti-inflammatory drugs, or just rest and time, rest from a high impact type of exercise that can help. However, if you continue to have recurrent symptoms over months, particularly over years, or if you have persistent symptoms over weeks or months, despite any conservative treatment, well, then we really recommend an arthroscopic procedure to help with those. We try to repair the meniscus whenever possible. Sometimes the tear pattern doesn't let us do that, because if we try to repair it, it may not heal. You may have worse symptoms later. And so it's either repair versus a partial meniscectomy, trying to keep as much of the meniscus as possible. This tear here is an example of a radial parrot beak tear. And so the tear is more so in the white zone. So you can see here with the knee hyperflexed, this tissue is pulled into the joint and it's pinched between the central portion of the two articulating surfaces. And that can cause pain and mechanical symptoms. So this tear wasn't amenable to fixation. If I put suture in it to try to fix it, I could do that, but it would never heal because the blood supply is so far away. And so what we do in that case is shave out the unstable portion of the meniscus here, trying to keep as much meniscus as possible at the periphery, so that you still protect the knee joint somewhat, protect the cartilage somewhat, so you don't get so much force on the cartilage, and also helps with stability. This is comparable to, or in contrast to, something called a flipped locked bucket handle tear of the meniscus. It's a vertical longitudinal tear pattern. You can kind of see this here after I flip that handle of the bucket back to the posterior aspect of the knee joint. These are arthroscopic pictures looking at the the lateral aspect of the knee in this right knee, where this part of the meniscus is really flipped up into the anterior compartment or the front part of the knee from a tear from the back part of the meniscus. And so you can see here, this tear is way back towards the periphery where there's good blood supply. And it's in this tear pattern, the vertical longitudinal tear pattern for fixation. And so after we flip it back, we kind of assess it and start putting suture in. And lo and behold, we put a bunch of sutures in to help preserve it, and this has a good chance to heal. And now you can see how much meniscus you have left to protect the cartilage. If that can't be done and you end up having something called a total meniscectomy or subtotal meniscectomy, where we have to take out most of the meniscus on one side of the knee joint or the other, you may be a candidate for something called an allograft meniscus transplantation, where we take meniscus from a cadaver, and whenever we talk about allograft, we're saying it's not from your own body. So typically it's from a cadaver. And we put that meniscus in your knee to replace it to help protect the cartilage and preserve the cartilage. Again, we're talking about knee preservation. But there's only a window of time to do this. And so it's after you have this subtotal meniscectomy and then go back to doing your normal life. If you start having pain and then just ignore it to a point where the cartilage starts to break down because it's not protected, well, then it may be too late to do the meniscus transplant, because we're not going to be protecting anything worth protecting because you already have arthritis. And so it's always after you have a subtotal meniscectomy and before you have the onset of arthritis or another cartilage injury. And this is just an example of a patient that I did over the last couple of years. This was an active duty naval air crewman who initially injured his knee playing Frisbee football, ultimate Frisbee, and ignored the injury because it was an ACL tear. He may or may not have had a meniscus tear at the time, but then went on deployment over to Japan and was messing around in the hangar, and all of a sudden had another injury to the knee. And I believe that's where he really tore his meniscus. He actually tore both the lateral and the medial meniscus. And so when he came back to the stateside, 6 months after the second injury, he had surgery by someone else, and they weren't adept at, I guess, fixing the meniscus as much or doing meniscus transplants, or felt that the meniscus wasn't repairable and just took out the meniscus, both the lateral meniscus here and the medial meniscus here. So for reference, this right knee looking at us, this is the arthroscopic picture of the lateral compartment, the arthroscopic picture of the intercondylar notch where the ACL and PCL lie, and the arthroscopic picture of the medial compartment. So he had almost his total lateral meniscus taken out, his total medial meniscus taken out, and then here in the intercondylar notch, you see he has no ACL. His PCL is intact, however, back here. And so when he came to me, I mean, he's probably 25-ish or so, 24, 25, young guy, active duty, wants to stay in the Navy. If we leave this knee like this, it's going to break down and become arthritic very soon, and he'll be med-boarded out of the Navy because he won't be able to perform his duties. And so I did a lateral meniscus transplant on him, took a cadaver meniscus and put that in his lateral compartment. You can see here, did his ACL reconstruction. So I did that in one sitting, let that heal in and let him rehab that, and then came back the next year and did the medial meniscus. And so you see some fraying of the cartilage here already, although this is nothing compared to full arthritis. And so you can see here now that he has the medial meniscus and a lateral meniscus that can help protect the cartilage going forward. And he's actually back doing his normal duties. He did not get med boarded out, and he's got a comfortable, non-painful, very functional knee. Here is postoperative X-rays after doing both lateral and medial meniscus transplants and ACL. And you can see here, he still has good joint space. That's what we're trying to accomplish, good joint space. And hopefully he'll continue to have this for years to come. And then we even got an MRI to confirm to check and see if his meniscus allograft transplantations were healing in. This is a sagittal view of his lateral compartment. This is his posterior horn of his meniscus transplant. Nice and homogeneous black signal. Same thing with the anterior horn. It's well revascularized and well healed in here. This is a coronal view, which is the facing forward view, where you can see the lateral meniscus here and medial meniscus, very nice and healed in. And then the sagittal view of the medial compartment, also nice and homogeneous signal here, the posterior horn of the medial meniscus transplant. Moving on to cartilage injuries. Again, we break them down into chondral defects, focal chondral defects versus osteochondral defects. And we can change kind of how the options of how we preserve that or fix that based on which one we have. Largely, I see more plain chondral defects than I do osteochondral defects. So you can see here, this is where there's the MRI of the osteochondral defect where there's bone involvement here. In this one, there is not. You can see kind of, this is the gray area of the cartilage. It kind of stops, then you kind of see it here. So this is devoid of any cartilage here. A little bit about something called Osteochondritis Desiccants. It's also an osteochondral defect or an OCD, but it's in a skeletally immature. Typically age between 10 to 15. Typically it's when the growth plates are still open. It's a totally different mechanism of onset than a focal chondral defect in an adult. It's non-traumatic. It has something to do with loss of blood flow to a certain region of the knee. It's typically seen on the lateral aspect of the medial femoral condyle or the medial compartment. It could be hereditary. There's insidious onset. And a lot of times it's difficult to diagnose. And treatment basically can be non-operative and just offloading the joint if the cartilage is still intact over top. We also kind of predict what kind of recovery someone will have based on the remaining growth in their growth plate or in their limb. And then if it does not heal on its own, there's other things we can do like drilling or internally fixing with a screw. Every now and then we have to do this Oates procedure, which you'll see later on in the talk here. And so the chondral defects I really want to talk about are these focal chondral defects. It's definitely different from arthritis. We went over that. It presents typically with a twist or direct trauma to the area. You may have a ligament injury or a meniscus injury concomitantly with this focal chondral defect, or it can be isolated. Most folks will see recurrent swelling. We call them recurrent effusions or water on the knee. And a lot of times you'll have some mechanical symptoms, particularly if the cartilage piece is still kind of connected and it's kind of flipping in and out, you have some mechanical symptoms there. Anytime you perform higher impact type activities, you'll have some pain with this. So on exam, again, effusion or swelling in the knee, water on the knee. And then depending on the location of the focal chondral defect, whether it's in the patellofemoral joint space or in the tibiofemoral joint space, you have a different presentation on physical exam. In the tibiofemoral joint space, the lateral or the medial compartment, you'll see some joint line tenderness. And then with the patellofemoral space, you'll have pain with some compression. If I kind of squeeze and push down on the kneecap and place you through a range of motion, you may have some pain with that. Imaging, again, we start with x-rays and really to determine, is there any bony involvement with this? CT scan may be something that we need, but MRI is really the gold standard. It's been better at diagnosing these focal chondral defects as MRI images have gotten better. And then there's this thing about bone edema. What edema is just inflammation or inflammation in the bone. And we want to know if there's inflammation in the bone behind the focal chondral defect or if there's not, because it may depend, it may determine what we want to do with treatment. So when we think about managing these, there are certain things we have to think about. Size is one of them. So anything less than a square centimeter, we can do certain procedures. Anything greater than a square centimeter, which ones I typically see, there's other things that we need to do. Again, we look at the bone edema, we look at location. We also try to figure out, can we do this arthroscopically, or do we have to make a small little incision to get in there and do this? And then we'll also have to look at unloading, possibly unloading certain parts of the knee joint. And that's what osteotomy is. Osteotomy just means cutting bone or breaking bone and shifting the bone so that we can unload one portion of the knee joint or another. So there's many options. Here are a few for cartilage preservation for focal cartilage defects. You have microfracture, which you kind of see in this area, in this picture here. We'll go over that. There's something I won't really touch on much, but there's something called de novo, which is juvenile cartilage transplantation or implantation, where we take donated juvenile cartilage cells or chondrocytes, which are more metabolically active, and put them into that defect, that pothole, to try to grow more cartilage. Something called biocartilage, we'll talk about that. And then there's this Oates procedure, which we'll really get into. There's the Osteochondra Allograft transplantation, where we take bone from the non-articulating part of the knee and put it into the defect. And then there's, and then that's limited by size. And then there's Osteochondra Allograft transplantation, where we take bone and cartilage from a cadaver and put it in the defect. And then we have something called matrix autologous chondrocyte implantation, and we'll get into that more. And that's a two-stage procedure where we take a biopsy of the cartilage, send it off, grow the chondrocytes, and put it back in your knee. So again, small lesions without bone edema. Your options are microfracture, which we take a little pick, like you saw in the last picture, and make these little holes in the knee joint, or just kind of scuffing up the bone here, get to a bleeding bone surface. That's called abrasive chondroplasty. The microfracture came out probably in the last 15, 20 years, maybe longer than that. And it was a good kind of bridge to help preserve the knee joint for some time. You may have heard a lot of basketball players that have had that done, but over time this breaks down, and it breaks down because it makes this fibrocartilage. This doesn't make normal hyaline cartilage for what you were born with. Fibrocartilage is type 2 cartilage or scar type cartilage. And the concept is that you make these holes down into the bone marrow, where it gets the stem cells and all the nutrients to fill into this area to make more cartilage. But again, it's not the cartilage that you're born with. And then the other option for the smaller, less than square centimeter lesion, even if you have bone edema, is to kind of replace that area with cartilage and bone from a non-articulating portion of the knee joint. You kind of get it up here from the edge of the lateral femoral condyle, or sometimes you can take it from the intercondyle notch here and put it into the defect here, but it is limited by size. This is just a picture of one of the ones I've done here. There's a smallish type of lesion. pretty good surrounding cartilage. We took the cartilage from another non-articulating part and put it in this area here and impacted it, try to get a good level area and get that to heal in. And this results in hyaline cartilage, or type 2 cartilage for which you were born with, which is better, sturdier, lasts longer. Now getting into these larger defects, greater than a square centimeter, we talked about de novo. I used to do biocartilage. We're using these extracellular cartilage matrix and mix it with PRP. We'll talk about that a little bit. I had okay outcomes with that, but again, I think that gives you a little bit more this fiber cartilage and not the hyaline cartilage is what we're trying to accomplish. And then the last two that we'll really get into are is the allograft oats and the Macy. I like to use the allograft oats for the tibial femoral compartment, medial lateral compartment, and then the Macy for the patellofemoral compartment. So this animation here that depicts how we do this biocartilage. We kind of prepare the defect. We do the microfracture in the bed of the defect to try to get the nutrients from the bone marrow below. And then we take this proprietary extracellular cartilage matrix and mix it with, so there's not chondrocytes, it's just the extracellular cartilage matrix, and mix it with something called PRP, or platelet-rich plasma. And we get it from your own body. So we draw your blood, spin the blood down, get the plasma layer, which houses all your platelets. And we know your platelets house all your growth factors. And we mix that with this extracellular cartilage matrix and makes a putty. And we put that putty into this area here and fill it up, and then top it off with fiber and glue to kind of hold it in there. And that's supposed to help regenerate cartilage. But again, this is more like fibrocartilage. Here's a guy I did. This is the lateral compartment here, arthroscopic view of the lateral tibial plateau, arthroscopic view of the trochlea here, fairly large lesions, but with good surrounding cartilage, so focal cartilage defect. Put holes in this area, did the microfracture, filled it with the biocartilage mixed with the PRP, and then kind of covered it with this fibrin glue to kind of seal it in. And so this is certainly an option. It's not as expensive as the de novo, not as expensive as the Macy, of what we'll talk about later on. Now moving on to Osteochondra Allograft transplantation. These are for large lesions of the medial or lateral compartment. These have to be fresh grafts, so these can't sit on the shelf for years and years. These grafts are typically, we put these in, some say you can do 35 days. I don't like to go past 28 days after procurement, but it goes through this, sterilization, washing, testing from the company. And by the time it's done that, you may have a week to put this in. So that takes a good 2.5 to 3 weeks to do. And so you only have about a week to get this graft into this area so that those chondrocytes still stay viable. We do this, we say, as a single stage procedure, but ultimately it's probably a double stage or 2-stage procedure, because typically we will have scoped your knee before and saw that you had this large focal defect in the medial lateral compartment. It did some type of cleanup, made sure that the surrounding cartilage was still pretty good and healthy and not arthritic or anything like that, and then come back and have done this. Every now and then I can really see on MRI and predict that the surrounding cartilage is good, and this is just a focal cartilage defect, and then it's a single stage procedure. I've done this both arthroscopic and I've done it mini open, like in this picture. Sometimes I've had to perform these osteotomies, cut bone to unload one side of the knee joint or the other, so that you don't put a lot of pressure on the transplantation. And we talk about mechanical access with that. And so this is an example of someone I did. This is a left knee. This is the lateral femoral condyle, or the lateral compartment. We prepared the bed here, and then took this donated cartilage and bone and put this in this area here. You can see how nicely it fits. It's a press fit. So the cutting guides actually cut this just slightly bigger than the hole, and so it kind of compresses the bone in. So we don't have to use any screws or anything to hold it in. The reason why this incision was so large is because I actually had to do an osteotomy to unload the lateral joint. So I had to cut the end of the femur bone and realign the mechanical axis so that the mechanical axis fell more through the medial compartment and not through the lateral compartment. This is another example of that, and this is where we had to use two plugs because of the large defect. You had this area here, and then you had this area here. So we call this a snowman type technique. And so we put one here posteriorly and one here anteriorly. And again, the rest of the cartilage looks pretty good. Moving on to autologous chondrocyte implantation. Now we call it matrix autologous chondrocyte implantation, or Macy. These are, again, for large lesions. I think these are best suited for the patellofemoral joint space just because you have an undulating surface. So it'd be harder to do a Osteochondra Allograft or autograft just because of that undulating surface and trying to match that up. This is definitely a two-stage procedure. We have to take a cartilage biopsy, like you see here, send it off, and in about 6 to 8 weeks, sometimes 3 months, we can then bring you back after those chondrocytes have been multiplied in the culture and put them back into that defect. And so the first generation of this, kind of depicted in this animation here, where they took the cartilage from a non-articulating part, cartilage biopsy. They then sent the cells off to be cultured and multiplied, and then came back, and to hold the cells in, we had to use this periosteal flap from the end of the femur, end of the tibia bone. We had to sew it in with these very thin sutures into the cartilage, leave one portion open so we can inject it in, then put one more suture in, and then cover it with fiber and glue. It was pretty arduous procedure. But now with this Macy, it comes on a porcine membrane. And so you can see here, this is the way it comes, and this is me pulling it out of the jar that it comes in, and it has cells already stuck to one side, and the other side is just the porcine membrane or pig membrane that it comes on. And so this is the undersurface of a kneecap here. And so we just have to size this area and then cut the graft, this graft, to match this size, and put it and stick it on there, and then put fiber and glue over top of it to hold it. It's a really good procedure, and it produces this hyaline cartilage, which you've been born with. And then also it's good for these undulating areas here. It kind of forms to the undulating areas of the trochlea, which is the end of the femur bone that the patella glides in, and on the undersurface of the patella. So in summary, we try to preserve the knee joint by preserving the meniscus and repairing the meniscus whenever possible. And we didn't discuss this as much, but as we get older, the number of repairable meniscus tears that I see decrease. But I'm pretty aggressive at fixing meniscus tears, even into folks in the 60s, to try to preserve the knee joint. There is a relatively small window of time for meniscus transplantation once you've had a meniscus taken out and the onset of arthritis. So it's good to know if you're having pain on that side of the knee joint after having a meniscus tear to get in and get seen and get evaluated to see if you are a candidate for meniscal transplantation. And then for the cartilage defects, the oats or the allograft oats is better for the medial lateral compartment, and the Macy procedure is better for the patellofemoral compartment. I think neoprene sleeves are great. I mean, they help folks feel like they have some stability, although it really doesn't give you any more structural stability. I think just the compression helps with any type of swelling or anything like that. And yes, I think NSAIDs are good if you can take them. So if you have a heart issue, you may not be able to take them. If you have a kidney issue or a gastric lining issue, or you have GERD, or you have had gastric ulcers before, you may not be able to take NSAIDs. One other thing is topical non-steroidal anti-inflammatories may be an option in those cases. Well, I think you need to get an X-ray. That's the biggest thing. So do you have arthritis or not? We don't know. You can have arthritis, you can have a pretty preserved looking knee joint, but have a focal cartilage defect or a meniscus tear. And so if you're having difficulty, I think you just need to get in and get seen so that you know, and we know what you're dealing with, and then we can better recommend certain treatment options for you. It sure sounds like it. If you have no cartilage, you have global loss of articular cartilage in one part of the knee joint or another, where there's not preserved or healthy surrounding cartilage. There's no way that this Macy procedure or an Osteochondra Allograft procedure is going to work for you. You have to have good surrounding cartilage for this to work. Sure, all low impact exercises are good to preserve your knee joint. So we're talking about walking, cycling, either whether that's spinning in a group class or in the gym, or cycling outside. Swimming is really good. And then just some resistance training. And so you get in the gym and you do lunges or mini squats, or sometimes leg extensions and leg curls. If you have patellofemoral issues or wearing away of cartilage up underneath the kneecap, I really don't recommend the knee extension, but just general strengthening can help with preserving the knee joint. The things you want to avoid, or what I'll tell folks that will wear your knee out quicker, are the higher impact type activities. And that's the running, jumping, pivoting, cutting, those types of things. Now, I'll never tell somebody not to do it. You just have to understand that you have a higher risk of having earlier arthritis than most. So if you're an adult, the likelihood of having pain from Osgoods Slaughter is low, because Osgoods Slaughter is a condition of skeletally immature individuals. Now, sometimes you can have a little ossicle bone that's inflamed, and I've seen that before, that's kind of lingered over time. And every now and then we have to go in and take that little ossicle bone out, and then you don't have any pain. But I'm wondering if that's your true issue, or is there something else going on? It's a possibility. It can help with the symptoms. And it may even help with healing a meniscus, depending on the stability of the knee, depending on where the meniscus tear is. But the jury is still out on that. And so PRP is different. PRP is more blood manipulation. Stem cell is probably your best bet in that situation if we're thinking about healing a meniscus tear. But again, it's still early to really tell. There's not enough studies out there for us to tell if that's really something that is happening. Good question. So for the Osteochondra Allograft transplantation or Osteochondra Autograft transplantation, recovery is typically 6 to 9 months. The bone part of it heals in within the first 8 to 10 weeks. But as far as getting the cartilage cells or protected cartilage cells so that you're not putting too much pressure on them, and then getting full recovery, getting back to normal sports, running, exercise, those things, that's probably more like 6 to 9 months. The Macy procedure is a little longer because we have to unload that joint a little longer for those cells, those chondrocytes to heal in. So that's more like 9 to 12 months. So medial plica is basically a band of tissue that we're all born with that sometimes doesn't recede, and it can get stuck over the anterior aspect of the medial femoral condyle which is the end of the femur bone, when you flex and extend. And so you may have some reproducible clicking or popping. Every now and then it can cause some swelling, slight swelling. And if it does over a period of time, and we get an MRI and it shows the plica and nothing else, sometimes you have to go in there and resect it arthroscopically, and that recovery is minimal, 4 weeks, if that. You can. If the meniscus tear is causing pain, then it means that there's something going on where the meniscus is not in the right place. So you saw that picture that I showed where we had to do that partial meniscectomy, that little parrot beak tear there, sometimes that could flip underneath itself, or in the, we'll call it medial gutter or lateral gutter, or continue to flip in and out of the joint where it puts more pressure on the cartilage. That can cause either a propagation of a tear, where you can make a repairable meniscus tear become irreparable over time, or just start to break down your cartilage because it's causing more pressure on the cartilage. And so, yes, if you're just trying to play through pain of a meniscus tear, it's not good. Not long term. If we do a partial meniscectomy, there's really no brace. If we do a meniscus repair, we put you in a brace temporarily, initially while you're recovering, to help protect the repair. Once we think that the repair is healed, you don't need a brace. It depends on the patient. So I've seen both. I like the fact that hyaluronic acid gel injections work, and there's many out there on the market. There's ones that you give 1 injection for, that up to ones you give 5 injections a week apart. And they help coat the cartilage that's breaking down and cushion the knee joint a bit. It's made of the similar substance to our healthy joint fluid. And so I do like the gel injections. If they don't work, then typically we go to the cortisone injections. Cortisone injections can be good, and you can have cortisone injections if they help you every 3 or 4 months if you need to, but not any more frequently than that, because they can also cause other issues with soft tissue breaking down, bone softening, things like that. And if you're a diabetic, cortisone injection will raise your blood sugar intermittently. It'll equalize after about a week or so, but it will raise your blood sugar. I believe so. They can. There are a bunch of studies out there. Some say they do, some say they don't. But there's no, you're not burning any bridges by using these, what we call nutraceuticals, the glucosamine and chondroitin sulfate. And so, but that's an over time type of thing. It's not that you get a knee injury, then you take those things and it makes it better. Now, this is something more for prophylaxis to help with knee joint health and pain.